Hi, it's Steph here. Welcome back to my channel. Today I want to do a short video touching on double antimicrobial coverage, as I've seen it in a few instances this past week. To start off, double coverage is often not needed. In this instance, when you get the culture and sensitivity results back, you can stop one if this pathogen demonstrates susceptibility to both of these agents. It may be needed in the rare instance, such as when you're treating a critically ill patient with risk factors for a multi-drug resistant pathogen, in which case two antimicrobial with overlapping coverage is started because there is a chance that one of the antibiotic may be resistant. Therefore, the two is more as a backup in case one is resistant. In another scenario where you might see double coverage is when we're covering multiple pathogens. So in patients where they're growing multiple bugs in their culture with different resistance profile, where we're not able to use one drug to cover both of the bugs, we may end up needing to pick two antimicrobial agents to treat the two bugs simultaneously. It is best practice though to use the narrowest spectrum of each of these agents if they are to be employed. And sometimes you might see two antimicrobial agents of the same class used for synergy purposes, such as for Enterococcus endocarditis, where you may use ceftriaxone and ampicillin as synergistic treatment. Whenever you see two or more antibiotic on a patient's regimen that seem to cover the same things, always look into the guidelines to see if there is an indication or recommendation for this need. In addition to looking at guidelines, also look at their microbiology cultures. What sort of pathogens and bugs is the patient growing from their culture results? Do the sensitivity data warrant this double or overlapping coverage if there's no indication of such in the guidelines? And also consider the agents that are chosen. Is a specific antimicrobial therapy there to cover a specific multi-drug resistant bug? For example, vancomycin is often added to antibiotic regimen to cover for MRSA, and oral ciprofloxacin may be added to regimen to cover for Pseudomonas. If after going through the guidelines, the culture results, as well as the antimicrobial regimen, and thinking about the coverage for your particular patient and their risk factors, and you still can't figure out why the patient is on two antimicrobial with overlapping coverage, then bring it up with a team, especially the infectious diseases team if they're involved in the patient's care, to question the need for the duplicate therapy. Sometimes there may be double coverage because one antibiotic or antimicrobial is unintentionally left on the profile when the other is started. An example of double coverage that I often see in practice that should always be questioned is double anaerobic coverage, such as if a patient is on piperacillin tazobactam together with flagyl, or a carbapenem such as ertapenem or meropenem with flagyl, especially if this flagyl is not used for C. difficile therapy. In this case, always question the need for the double anaerobic coverage and seek to either stop the flagyl or, even better, try to narrow the regimen down to the infection that you are targeting and to the patient's risk factors. For example, if they don't have risk factors for Pseudomonas, then we could potentially narrow the piperacillin tazobactam and flagyl regimen to something like ceftriaxone and flagyl, depending on what infection you're empirically covering.